Welcome to PRISM Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
So, I want you to imagine a patient for a second. Let's say 38 years old.
Okay, 38.
Yeah, 38. A complete non-smoker, exercises every single day, eats an excellent diet, and has a totally normal weight.
Sounds like someone who's going to outlive both of us.
Right. But now I want you to imagine them rolling into your ICU with a massive anterior STEMI at 2 a.m.
Oof. Yeah, that's the nightmare scenario.
It is. And the crazy thing is, in one specific demographic in the United States, 25% of heart attacks happen before the age of 40.
Wow, wait, a quarter of them?
A quarter. And half occur before 50. And, if your immediate instinct as a clinician is to look for some, super rare genetic anomaly or maybe an undisclosed cocaine habit, you are actually falling into a massive trap. And you're missing millions of people.
Yeah, you're talking about the trap of the visual heuristic, which is, it's such a huge problem. We are so deeply conditioned in our training to look for this very specific, very obvious phenotype of cardiometabolic disease.
Exactly. The classic textbook presentation.
Right. And when that phenotype isn't sitting right there in front of us, we just sort of assume, oh, well, their vascular system must be perfectly pristine.
Which is so dangerous.
It really is. Anyway, welcome back to a special PRISM Rounds edition of The Deep Dive. For our FOMED listeners, the busy clinicians, residents, and fellows tuning in, PRISM Rounds is our practical, evidence-focused pulmonary, critical care, and sleep medicine format.
Where we try to make sense of the literature.
Exactly. We are two experienced ICU attendings, taking complex papers and translating them into, actual bedside thinking, stuff you can use on rounds tomorrow.
And today's deep dive is, it's a little different. It's not about tweaking a ventilator setting or trying to choose between vasopressors.
Right. No ARDS or sepsis.
Now, we are zooming way out. We want to look at the silent trajectories of risk that, frankly, begin decades before a patient ever crashes onto one of our ECMO circuits.
Getting to the root of the issue.
Exactly. So we are formally unpacking a really pivotal primary source today. It's the 2026 Journal of the American Heart Association article by Petamalu and colleagues.
A fantastic paper.
It really is. It examines the prevalence and the trends in cardiovascular risk factors among middle-aged South Asian adults in the U.S. And to give us the vital clinical background, we are also heavily referencing an excellent March 2026 JMA Medical News Perspective article by Jennifer Abbasi.
Which is such a good read. And the core thesis we're evaluating today is just striking. Basically, South Asian adults appear to enter midlife with a significantly heavier burden of critical cardiovascular risk factors.
Even when their lifestyle looks great.
Exactly. Even when their reported lifestyle behaviors look relatively favorable compared to other demographic groups.
Right.
So the clinical imperative for you, the listener, is all about earlier vigilance.
Right. Catching it before it's a catastrophe.
Yeah, it requires initiating those prevention conversations so much earlier in life, rather than, just rigidly adhering to a traditional screening algorithm that was largely built on entirely different demographic data.
Now, I can already hear a skeptical intensivist listening to this and asking, why are we dedicating PRISM rounds to a preventive cardiology paper?
Fair question. I mean, we staff intensive care units, right? Not outpatient lipid clinics.
Exactly. But as intensivists, we live entirely downstream from prevention failure. Like, when the primary care net fails, we are the ones catching the fallout at 2 a.m.
Yeah, we're the ones managing the catastrophic plaque ruptures.
The devastating stroke.
The decompensated heart failure admissions that, seemingly came out of absolutely nowhere.
And we're also the clinicians running the family meetings after those events.
Oh, man, those meetings are the hardest part of the job.
They really are. And we staff the post-ICU and pulmonary clinics where we follow up with these survivors, and we're trying to map out a secondary prevention strategy. And frankly, the ICU is where that visual heuristic trap we just mentioned becomes incredibly dangerous.
Totally. Because in medical training, pattern recognition is survival.
You have to have it to get through residency.
Right. You learn to spot the classic phenotype of cardiovascular risk.
Yeah.
The older, visibly obese, clearly insulin-resistant patient with metabolic syndrome.
The classic metabolic syndrome picture.
Yeah, and that shortcut just gets hardwired into our clinical gestalt. But that completely defies the standard risk stratification algorithms we use every day when the patient doesn't look like that.
Right. If the mechanical load, like the visible obesity, if it isn't there, what is driving the vascular collapse?
Exactly.
If a population develops early cardiometabolic disease despite a lower average body mass index, relying on our classic visual training means we will literally look right past the pathology until it becomes an acute, life-threatening crisis.
Which is terrifying.
It really is. So to understand how this risk stays hidden from our standard clinical tools, we need to look at how these researchers actually captured these patients. Let's break down the architecture of the study design.
Yeah, let's get into it. Because the methodology here is just a massive undertaking in epidemiological harmonization.
Harmonization is a good word for it.
Yeah, the authors combined longitudinal data from two major cohort studies. First, they utilized the Masala study, that's the mediators of atherosclerosis in South Asians living in America.
That's right.
Right. And this cohort specifically enrolled South Asian adults in the U.S. to find as individuals tracing their ancestry to countries like Bangladesh, Bhutan, India, the Maldives, Nepal, Pakistan, and Sri Lanka.
And just for context, we are talking about a demographic representing roughly a quarter of the global population.
A quarter of the world. It's massive.
And about 6.4 million people in the U.S. alone. Yet historically, this specific group has been chronically underrepresented in the foundational cardiovascular megatrials that basically wrote our current guidelines.
Which is exactly why Masala was created in the first place, to fill that massive blind spot. So to establish a comparative baseline, the researchers then harmonized the Masala data with the MESA cohort.
That's the multi-ethnic study of atherosclerosis, right?
Exactly, MESA. And MESA included white, black, Hispanic, and Chinese adults in the U.S. Now, here's the really brilliant part of the design. The researchers restricted their analytic sample to focus strictly on adults aged 45 to 55 at the baseline of the study.
Oh, I love that. Isolating that specific decade is brilliant.
Why do you say that?
Because age 45 to 55 is it's the crucible of vascular biology.
The crucible, I like that.
It is. It's the inflection point where decades of prior lifestyle habits, genetic predispositions, and environmental allostatic load all of that either crystallizes into measurable chronic disease or it doesn't.
Yeah, it's where the bill comes due.
Exactly. For scale, so you guys listening have an idea of the numbers, the final sample included 554 South Asian adults compared alongside 796 white adults, 588 black adults, 517 Hispanic adults, and 245 Chinese adults.
So really solid sample size to compare across.
Very solid. And they tracked clinical and behavioral risk factors by gender over roughly a decade, watching how these individuals transition from age 45 to age 55.
Yeah, we should probably define the boundaries of the data before we dive into the actual results.
Always a good idea. Caveats first.
Right, because this is an observational cohort analysis. It excels at identifying longitudinal patterns and mapping out the natural history of risk over time.
Right, it shows us the trajectory.
Exactly. It is not, however, a randomized controlled trial designed to test a specific therapeutic intervention or, validate a rigid screening schedule. It points a massive spotlight at the epidemiology, but it doesn't hand us the finalized treatment protocol.
Right, it identifies where the system is failing, which tells us where we need to aim our diagnostic tools. So let's look at what they actually found when they pointed that spotlight at these adults exactly as they entered midlife at age 45.
Spoiler alert. It's not great.
No, the clinical risk profile at baseline is deeply concerning.
It's a severe baseline burden. I mean, looking at the hard clinical numbers for prediabetes alone, South Asian adults had the highest prevalence among all the groups studied.
The highest out of everyone.
Out of everyone. We are looking at roughly 31% of South Asian men and 18% of South Asian women having prediabetes at age 45.
That's almost a third of the men.
A third. And to anchor that for comparison, that contrasts with just 4% of white men and 6% of white women in the harmonized cohort.
31% versus 4%. That is nearly an 8-fold difference in men at age 45.
This is staggering.
That is not some subtle statistical artifact or background noise. That is a massive population-level metabolic failure occurring a full decade before most traditional screening guidelines recommend aggressive intervention.
And the hypertension data reinforces that exact same systemic failure. South Asians demonstrated the second highest prevalence of hypertension, affecting 25 to 30% of the participants.
And who is higher?
That burden was lower only than Black men and women in the cohort. Furthermore, dyslipidemia was highly prevalent, affecting roughly 78% of South Asian men and 54% of South Asian women at age 45.
78% with dyslipidemia at 45.
Nearly 4 out of 5 men.
Entering midlife with that degree of clinical risk sets a really dangerous trajectory. I mean, what happens to the vascular system as these individuals march toward age 55?
Well, as you might expect, the clinical risk factors inevitably worsened across the board for all demographic groups over that decade. We all get older, things get worse.
Right, nobody gets healthier in their 50s by doing nothing.
True. However, the divergence in risk became significantly more pronounced. By age 55, South Asian adults had the highest estimated hazard probability of developing full-blown diabetes of any racial and ethnic group in the analysis.
And here's the point where the standard medical narrative just completely collapses on itself.
Oh, here comes the paradox.
It is a huge paradox
Yeah.
because in classical medical teaching, bad metabolic outputs are driven by bad behavioral inputs.
Right. That's what we're taught day one of med school.
Exactly. If the blood sugar, the blood pressure, and the lipids are this disproportionately deranged, the assumption is that the cohort must be consuming a highly obesogenic diet, maintaining a completely sedentary lifestyle, and smoking a pack a day.
Right. But the central paradox of this entire data set is that the exact opposite was observed.
It really is wild.
Paradoxically, the South Asian cohort demonstrated some of the healthiest lifestyle behaviors on paper.
On paper.
Right.
Yeah.
At age 45, the South Asian men and women reported the highest diet quality scores as measured by the Alternative Healthy Eating Index.
Okay, we should definitely clarify what the Alternative Healthy Eating Index, or AHEI, actually measures, because it is much more rigorous than just a simple, calorie count or a BMI check.
Oh, absolutely. It's a very detailed metric.
It specifically tracks the intake of foods and nutrients that are strongly predictive of chronic disease risk. So it scores highly for things like vegetables, whole grains, and polyunsaturated fats.
The good stuff.
Right, the good stuff. And it heavily penalizes for sugar-sweetened beverages, red meat, and trans fats.
And they scored the highest on that rigorous metric. The highest.
Which is incredible given their risk profile.
Furthermore, they had the lowest prevalence of smoking and among the lowest rates of alcohol use across the entire cohort.
Low smoking, low drinking, great diet.
And their reported exercise levels were completely comparable to most other groups. But here is the real kicker. Crucially, South Asian men had a lower average body mass index than Black, Hispanic, and white men, while South Asian women had a lower BMI than Black and Hispanic women.
I really want to pause on this because it requires a fundamental rewiring of how we assess our patients in the clinic or the ICU.
It breaks the algorithm.
It shatters it. They have lower BMIs, superior diet quality, minimal smoking or alcohol use, and adequate exercise. Yet nearly 80% of the men have dyslipidemia and a third have prediabetes.
It's like the math isn't mathing.
Exactly. The math is totally broken. If the mechanical load of obesity is absent and the behavioral inputs are supposedly favorable, our diagnostic instruments are clearly failing to capture the true pathology.
They're completely missing the boat. And the JAMA Medical News Perspective article by Jennifer Abessi addresses this gap directly, which I think is why it pairs so well with the JHA paper.
Oh, the JAMA piece is fantastic. It meticulously deconstructs the bluntness of body mass index as a tool.
Because BMI is, at its core, just a two-dimensional mathematical ratio of height to weight.
That's all it is?
It offers absolutely zero insight into actual body composition, muscle density, or fat distribution.
It treats a pound of muscle exactly the same as a pound of visceral fat.
Precisely. The Perspective article highlights that standard measurements like BMI fail so spectacularly in this demographic because they cannot account for specific physiological differences in how South Asian bodies actually store adipose tissue.
And that is a phenomenal example of how relying on an aggregate metric obscures regional pathology.
Oh, regional pathology is the perfect term for it.
Right. Because it is not about the total volume of adipose tissue a person carries. It is entirely about the anatomical location and the endocrine behavior of that tissue.
Yeah, and a Masala study previously established that South Asian individuals tend to have less lean muscle mass overall,
Yeah.
coupled with a highly pronounced tendency to store excess fat internally.
Deep inside the abdomen.
Right, we were talking about visceral adiposity. This is fat infiltrating the omentum, wrapping tightly around the internal organs and accumulating directly inside the hepatic parenchyma.
And we need to be really clear about this. Visceral fat is not passive insulation. It's not just extra padding.
No, it is highly active.
It is an unauthorized rogue endocrine organ.
A rogue organ, I love that.
It really is. Because unlike subcutaneous fat, which is, relatively metabolically inert, it just sort of sits there, visceral adipose tissue is packed with macrophages.
It's highly inflammatory.
Highly. It actively secretes inflammatory cytokines like interleukin-6 and TNF-alpha directly into the portal circulation.
Straight to the liver.
Straight to the liver. It floods the liver with free fatty acids, effectively poisoning the hepatic insulin receptors and driving severe hepatic insulin resistance.
And that's the genesis of the prediabetes right there.
Exactly. So a patient can have a completely, quote-unquote, normal BMI. They can appear entirely lean in street clothes, but on a cellular level, they are metabolically drowning in highly inflammatory visceral fat.
And Dr. Namratha Kandila, who is a co-principal investigator in the Masala study, points out in the JAMA article that this unique body composition acts as a massive metabolic accelerant.
An accelerant, yeah.
South Asian individuals develop severe clinical risk factors at much, much lower weight thresholds, because that specific fat distribution is so heavily tied to insulin resistance and endothelial dysfunction.
Okay, so the body composition piece makes perfect sense. But I am going to push back a little bit on the behavioral data here, specifically the dietary and exercise inputs.
Okay, play devil's advocate.
Well, we are relying heavily on food frequency questionnaires and self-reported exercise logs for this data, right?
We are.
And there is an enormous amount of literature out there on the healthy user biases and the profound, almost comical unreliability of dietary recall.
Well, people are terrible at remembering what they ate.
Right. Patients, and let's be honest, we physicians do this too,
Yeah.
routinely overestimate their vegetable intake and vastly, vastly underestimate their sedentary time.
I only had one slice of pizza, right?
Exactly. I barely sit at all. So my question is, are these survey tools simply painting a falsely optimistic picture of the cohort's actual habits?
It's a really valid question, and the vulnerability of self-reported data is always a critical point of friction in epidemiology.
It's the Achilles heel of these studies.
It is. And Dr. Nilay Shah, a co-author of the JAE study, actually acknowledges this exact point in the JAMA piece. He admits that dietary assessments are inherently flawed tools.
Good. I'm glad they admit it.
But, and this is the important part, the researchers cross-referenced these surveys with metabolic panels and biomarker data to check for reporting fidelity.
Oh, so they checked the receipts.
They checked the receipts. And even when statistically adjusting for recall bias, the gap between the reported behaviors and the clinical outcomes is far too massive to be explained away by survey errors alone.
It's too big a chasm.
Right. So Shah points to major unmeasured variables that act as hidden drivers of risk, starting with total sedentary time.
And that distinction between intentional exercise and total sedentary time is biologically crucial.
It's everything.
Because you can perform 45 minutes of moderate intensity exercise in the morning, which satisfies the survey requirement and looks fantastic on a chart.
You check the box.
You check the box. But if you spend the remaining 15 waking hours sitting rigidly at a desk, your lipoprotein lipase activity completely plummets.
Yeah, your muscles just go to sleep.
Exactly. Your skeletal muscle insulin sensitivity drops significantly. The standard surveys rarely capture the profound metabolic toxicity of prolonged, uninterrupted sitting.
And beyond just daily movement patterns, the JAMA article emphasizes the immense unseen weight of early life and environmental exposures.
This part is fascinating.
It really is. Consider the cohort demographics here. Nearly all the Masala participants are first-generation immigrants.
Right, they moved to the U.S. as adults.
Exactly. So when we analyze their risk at age 45, we're looking at a snapshot that completely ignores the first 4 decades of their lives.
The formative years.
Yeah. Those decades were shaped by entirely different environmental architectures, distinct physical activity infrastructures, and the profound psychosocial allostatic load associated with the act of immigration itself.
And you cannot simply look at a patient's current behavior in 2026 and ignore their historical metabolic debt.
Metabolic debt, that's a great way to phrase it.
If a patient is eating perfectly and exercising today, they are still carrying the physiological scars of their past environment. The JAMA piece actually touches on air pollution, which is highly relevant here given the severe particulate matter levels in many South Asian cities.
Yeah, and air pollution is no longer just considered a pulmonary issue, right?
Oh, absolutely not. It is a recognized, potent driver of systemic cardiovascular disease.
How does that actually work pathologically?
Well, fine particulate matter, specifically PM2.5, is so small that it translocates across the alveolar epithelium directly into the bloodstream.
Straight into the blood.
Straight in. And once there, it induces massive systemic oxidative stress, it triggers the release of pro-inflammatory mediators, and it directly causes endothelial nitric oxide synthase uncoupling.
Wow, so it just strips the vessels of their protective layer.
Exactly. That process fundamentally degrades the vascular endothelium over decades. So a patient moving to the U.S. at age 30 brings that established endothelial dysfunction with them on the plane.
That is wild to think about. But we also have to address the structural and genetic biomarkers that completely bypass lifestyle interventions altogether.
Right, the stuff you can't outrun on a treadmill.
Exactly.
Right.
If we're talking about unmeasured drivers of early atherosclerosis, we absolutely have to talk about lipoprotein.
Yes, Lp(a). We have to talk about.
Elevated lipoprotein, or LPA, is highly prevalent in South Asian populations and represents a massive, completely independent risk factor for ASCVD.
And from a pathophysiological standpoint, LPA is incredibly destructive.
It's a menace.
It is a total menace. It basically consists of an LDL-like particle bound to a unique glycoprotein called apolipoprotein.
And the structural biology of apolipoprotein is what makes it so uniquely lethal, right?
Exactly, because it shares a high degree of amino acid sequence homology with plasminogen.
Plasminogen, the clotbuster precursor.
Right, and because it looks so structurally similar to plasminogen, it actively competes for binding sites on the endothelial surface and directly on fibrin clots.
But it doesn't do the job of plasminogen.
No. Unlike plasminogen, it cannot be cleaved into active plasmin. So it sits there and competitively inhibits fibrinolysis.
Which means LPA delivers an atherothrombotic double whammy.
The worst of both worlds.
Yeah, it drives cholesterol directly into the arterial intima, accelerating plaque formation, while simultaneously inhibiting the body's ability to break down clots when they form.
It's highly proatherogenic and highly prothrombotic.
And the kicker is that LPA levels are almost entirely genetically determined.
Right, you're born with your level.
Pretty much.
Yep.
Diet, exercise, and standard statin therapies barely touch it at all.
So if a clinician does not specifically order an LPA assay, the patient will look perfectly healthy on a standard lipid panel right up until they experience a catastrophic plaque rupture.
Which brings us back to that 38-year-old STEMI patient you mentioned at the start of the episode.
Exactly, it all ties together. Now, if this visceral fat and this genetic predisposition behaves so aggressively, I'm wondering, does it manifest differently across genders?
Oh, absolutely it does.
Given the different baseline hormonal profiles and the unique physiological stressors men and women face in their 40s, I have to imagine the trajectories diverge.
They do. And the data on women reveals a staggering metabolic acceleration. The JHA paper found that between the ages of 45 and 55, South Asian women experienced a disproportionate, massive increase in the prevalence of prediabetes.
Just in that 10-year window.
Yes. The rate of increase during that specific 10-year window was significantly steeper than what was observed in white and black women.
And the JAMA commentary makes a really vital connection here regarding pregnancy as a predictive window for that later risk.
Yeah, it brings up gestational diabetes.
Right. Asian individuals in the U.S. experience the second highest rates of gestational diabetes of any racial and ethnic group.
And gestational diabetes is basically the ultimate physiological stress test for the vascular system and the pancreas.
It really is a stress test.
During pregnancy, the placenta naturally secretes human placental lactogen and other hormones that induce profound systemic insulin resistance.
Which is supposed to happen, right?
Right. It's a normal physiological mechanism to ensure adequate glucose delivery to the growing fetus.
But the maternal pancreas has to massively upregulate insulin production to overcome that placental resistance.
It has to work in overdrive.
Exactly. And if the maternal beta cells do not have the functional reserve to meet that immense demand, the maternal blood glucose spikes, unmasking gestational diabetes.
Which essentially reveals a pre-existing fragility in the beta cell reserve and the vascular endothelium long before traditional type 2 diabetes ever develops.
It's like a crystal ball showing you what's going to happen 10 years later.
Exactly. And the endothelial dysfunction triggered during that gestational period often persists long into the postpartum phase.
And we know the clinical reality on the wards. Cardiovascular risk conversations in women are already chronically delayed due to deeply entrenched gender biases in medicine.
Oh, without a doubt. Women's heart disease is frequently underdiagnosed or just brushed off as atypical symptoms.
Anxiety, stress, you name it. Now, compound that baseline gender bias with a patient who is South Asian, who has a completely normal BMI, who looks externally healthy, and whose primary risk factors are hidden in visceral fat or unmeasured LPA.
They're a ghost in this system.
Exactly. That patient is virtually invisible to standard algorithm-driven screening protocols. The data clearly demonstrates why delaying intervention until they fit a quote-unquote classic phenotype is incredibly dangerous.
Because by the time they fit the phenotype, the traditional predictable risk factors are already deeply entrenched in causing irreversible organ damage by midlife.
The damage is done.
Right. The authors fundamentally argue that the current timeline for cardiovascular screening is dangerously delayed for this specific demographic.
So we need to move from analyzing the epidemiology to practical bedside translation.
Yes, let's bring it back to the ICU.
How does this research actually alter our clinical instinct on rounds tomorrow morning? For the residents and fellows listening right now, what is the immediate bedside translation? How do we change the way we frame these patients during presentations?
Okay, first and foremost, we must stop framing younger South Asian patients presenting with severe cardiometabolic disease as an anomaly.
Stop calling them zebras.
Exactly. When you read the background literature, the statistics are definitive. 25% of heart attacks in this group occur before the age of 40. That is not a rare zebra. It is an established population-level pattern.
So if a 38-year-old South Asian man comes into your ICU with an acute myocardial infarction, you should not be standing around the workstation scratching your head wondering how on earth this happened.
No, you should be recognizing that the systemic failure actually happened 15 years ago.
When the standard screening guidelines told his primary care doctor he was too young to worry about it.
Exactly. Second bedside translation. Clinicians must stop relying on appearance or BMI alone to estimate risk.
Throw the visual heuristic out the window.
Yes. Dr. Carol Watson, who is a cardiologist and a co-principal investigator of the MESA study, is quoted in the JAMA piece offering this brilliant, direct advice. She explicitly warns, quote, "Don't think only about the typical sort of obese diabetic phenotype."
That's a great quote.
It is. She highlights that the volume of young, non-obese South Asian patients presenting with severe, advanced disease is striking. The absence of obesity is absolutely not the absence of risk.
Third takeaway for the bedside. We need to actually leverage the tools the cardiology societies have already given us.
Right. They've updated the guidelines.
They have. South Asian ancestry is formally recognized by the American Heart Association and the American College of Cardiology as an official risk-enhancing factor.
And they did that back in 2018, right?
Yes, in their 2018 cholesterol management guidelines. So this isn't just demographic trivia to, casually include in a history and
This is actionable data.
It is a clinical trigger that should meaningfully lower your threshold for initiating statin therapy and aggressive risk modification.
And fourth, the bedside translation requires a massive paradigm shift in the actual timeline of our prevention conversations.
We have to start earlier.
Much earlier. The JAMA piece notes that the preventive cardiology program at UCLA actually begins screening their South Asian patients at age 18.
18? That's incredible.
Yeah, they are not waiting for a patient to hit their 40th birthday to order a basic lipid panel. They are actively hunting for the risk while the patient is still in college.
Which is exactly what we should be doing. But before we completely rewrite our hospital admission orders based on a single podcast deep dive, we have to perform the mandatory ICU attending reality check.
Ah, yes. The limitation section.
Always. What are the methodological boundaries and limits of this data?
The caveats are crucial for keeping our clinical application honest. First, as we established earlier, this is an observational cohort analysis.
Right.
It proves that the elevated risk is definitively present, and it maps the longitudinal trajectory beautifully. However, it is not a randomized screening trial.
It doesn't give us the perfect protocol.
Right. It does not hand us empirical proof of the absolute best evidence-based screening schedule, nor does it define the optimal pharmacological treatment strategy. It shows us the house is structurally compromised, but it doesn't tell us exactly which reinforcement technique prevents the collapse.
There is also a significant issue with time period confounding that we really need to address here.
Yes, the harmonization issue.
Right. The Masala and MESA studies were harmonized to create this data set, but they enrolled patients during slightly different historical windows.
MESA was earlier, wasn't it?
Yeah, MESA began enrollment around the year 2000, whereas Masala started roughly a decade later in 2010.
And that 10-year gap introduces profound secular trends into the analysis.
A lot changed in that decade.
A lot. Over that specific decade, public health messaging shifted dramatically. We saw the introduction of trans fat bans, significant evolutions in dietary guidelines, and massive changes in the aggressiveness of statin prescribing.
So comparing behaviors from 2000 to behaviors in 2010 inherently involves some degree of historical mismatch.
It does, and we have to acknowledge that.
I also want to address a really dangerous cognitive leap that often occurs when discussing this kind of ethnic-specific data.
Oh, I know where you're going with this,
Okay.
the genetic determinism argument.
Exactly. When clinicians hear about elevated risk in a specific ethnic group despite healthy behaviors, the immediate lazy assumption is genetic determinism.
They assume the population just has, quote-unquote, bad genes.
Right, which breeds a terrible therapeutic nihilism. Like, why bother with aggressive lifestyle counseling if it is all just genetic destiny?
Yeah, why try if it's coded in your DNA?
Right. So, does this paper suggest we should just accept this as a genetic inevitability?
Absolutely not. And the authors of the JAJ paper are highly explicit in pushing back against genetic determinism.
It's an important point to clarify.
Very important.
Mm.
They carefully state that in disparities, research, race, and ethnicity must be viewed primarily as social constructs, not purely biological or genetic categories.
That is a critical distinction to make. It moves the focus away from biological fatalism and toward actionable systemic factors.
Exactly. The mechanisms driving this immense risk are highly multifactorial. While genetic components like LPA polymorphism certainly play a role, the risk is deeply entangled with environmental exposures, the complex physiological stress of acculturation, systemic barriers to healthcare, and the chronicity of the allostatic load.
It's a web of factors.
It really is. In fact, prior Maslow research actually demonstrated that immigrants who strongly maintained traditional cultural dietary patterns had different risk profiles compared to those who completely assimilated into standard Western diets.
So it's a dense, interactive web of environment, behavior, and biology.
Precisely. It's not just genes.
Well, if excellent epidemiology doesn't just close the case, but instead tells us exactly what clinical trial we need to run next, what does the future of this research look like?
Where do we point the grant money?
Exactly. Where's the funding going?
The academic wish list moving forward rests on three major pillars. First, we must study much younger cohorts.
We have to move upstream.
Way upstream. If the divergence in clinical risk is this severe at age 45, the underlying pathology clearly initiated much, much earlier. The JAMA article notes that Dr. Shah has already launched the Masala second-generation study.
Oh, looking at the kids of the original cohort.
Exactly. They're tracking the U.S.-born young adult children of the original participants.
That is going to yield some fascinating data.
It already is. In this cohort, who are mostly in their 30s right now, researchers are already documenting elevated BMIs, dyslipidemia, and concerning behavioral trends like high rates of e-cigarette use. We have to trace the pathology back to its origin.
Okay, what's the second pillar?
Second, we need vastly superior phenotyping. We have to move beyond the blunt instruments of BMI and standard lipid panels.
We need high-definition data.
Right. Future studies require objective, high-resolution measures of visceral adiposity, utilizing DEXA scans or MRI quantification.
And stop relying on food questionnaire.
Yes, we need objective physiological tracking using wearables to accurately capture sedentary time rather than relying on memory-based surveys.
Smartwatches, continuous glucose monitors, that kind of thing.
Exactly. We also need routine LPA assays incorporated into the baseline data of all these studies, and we need highly granular, meticulously tracked data on pregnancy history and gestational diabetes outcomes.
And the third pillar?
The third and most critical pillar must be intervention trials. Epidemiology can describe the disaster, but interventional trials are required to actually stop it.
We need to know what works.
Right. We need randomized controlled trials, testing whether earlier recognition, culturally tailored lifestyle interventions, and earlier pharmacological treatments, such as initiating statins, PCSK9 inhibitors, or GLP-1 receptor agonists at much younger ages, actually improve hard morbidity and mortality endpoints in this specific population.
We need empirical proof that moving the screening finish line actually alters the physiological outcome for the patient.
Exactly.
Well, we have covered an immense amount of pathophysiology and epidemiological data today. Let's distill this complex discussion into our sharp take-home messages for the clinician walking onto the wards tomorrow morning.
Let's do it.
Number 1. South Asian adults enter midlife with a significantly heavier cardiometabolic risk burden, and this occurs despite them reporting relatively healthy lifestyle behaviors compared to other demographic groups. The risk is alarmingly high, and behavior alone does not explain the discrepancy.
Number 2. The visual phenotype is incredibly deceptive and clinically dangerous. A completely normal BMI can easily mask severe, metabolically toxic levels of visceral adiposity and profound insulin resistance. Do not trust your visual heuristic. The absence of obesity is not the absence of disease.
Number 3. ICU clinicians, our trainees, and our outpatient colleagues must fundamentally adopt an attitude of earlier cardiovascular vigilance. We need a significantly lower threshold for screening in this population. Do not wait for the textbook age cutoffs to initiate a deep dive into a patient's lipid profile or glycemic control.
And number 4, remember that this risk is highly multifactorial. It is a complex interplay of specific body composition, early life environmental exposures like air pollution, genetics such as LPA, the psychosocial stress of immigration, and pregnancy-related complications like gestational diabetes. It requires a holistic, deeply curious clinical approach, not just checking boxes on an algorithmic form.
Which brings me to a final provocative thought to leave you with.
Hit us with it.
We spend a massive amount of our professional lives in the intensive care unit treating the acute, catastrophic, end-stage failures of the vascular system. We throw pressors, mechanical ventilators, and mechanical circulatory support at the devastating results of atherosclerosis.
We do. We fight the fire after the house is burning.
But if we want to truly reduce the census of our intensive care units, maybe we need to realize that middle-age cardiovascular risk actually begins taking root before our patients even hit their 30s.
It's a sobering thought.
What if the most effective critical care intervention you make this entire year isn't adjusting a PEEP valve or placing a central line? What if the most profound intervention you make is simply pulling aside a healthy-looking 35-year-old family member at the bedside and asking them, hey, have you ever asked your doctor to check your LPA?
I love that. It's a powerful perspective that redefines the scope of our specialty. We aren't just treating the single patient in the bed. We are looking at the entire family unit, recognizing the shared environmental and genetic risk, and trying to alter their collective trajectory before they end up in our unit.
It is about hiking upstream to figure out why people are falling into the river in the first place.
Exactly.
Thank you for joining us on this PRISM Rounds edition of The Deep Dive. We hope this changes the way you look at the pathophysiology of your next patient, and maybe even the way you approach your own cardiovascular health.
Keep questioning your clinical assumptions. Keep looking beyond the surface phenotype, and we will see you on the wards.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.